Hi, this is Dr. Rohit Punga, and I welcome you to the round 4 of coffee tutorials in oral and maxillofacial surgery. So today, our topic of discussion is going to be third molar surgery. And when I say third molar surgery, of course, it's a huge topic, so I'm just going to give you a very basic tip on the assessment of the third molars. Now, this is something which is normally not taught in college lectures and the other tutorials, etc. But this is something which is going to really help you in making your practice very easy when you come to assess a third molar and when you come to perform your surgery, because your planning is the key to success. So having said that, I would want you to just focus on one important thing, that when you plan to remove your tooth, the entire way you plan your surgery is usually that you plan an incision, then you go ahead with your removal of the bone guttering, and then you section your tooth, you apply your elevator, and finally your tooth is out. And of course you perform wound toilet and closure after that. But the way that I practice my third molars, I'm going to share the secret of doing third molar surgery in an absolutely different way. It's more about planning it the retrospective way. So this is something that I practice personally, and this is how it's done. Now, normally when you see a radiograph, you will find that the roots will have a particular way, that they'll be having a tilt, or they may be straight, or they may be bulbous, or they may be having some kind of gradual curvature. So that is the first thing that I see when I see a radiograph. I first of all see the root curvature and its the relationship of that root with the canal. So the first thing that I decide in my third molars is that what is the path of exit of this third molar, or the path of withdrawal of this third molar. So the most curvaceous root, the most antagonizing root to the path of curvature will decide the path of curvature. Having said that, the second thing that I see is that where do I need to apply the elevator to be able to remove this tooth. When I am applying the elevator at a particular point and the tooth is going to be removed, it's obviously either going to have some interferences or some hindrances from adjacent teeth, from the bone, or from its own path of exit. So that will make me take a call on where I do want to section this tooth, whether I want to section this tooth, whether I do not want to section this tooth. So this call is of course taken as what you call as the surgical odontectomy is always planned on the axis of the tooth, which is a classical thing. That's not something new, but when it is planned is important. So the first thing I decide is the path of withdrawal. The second thing I decide that where is the point of application of elevator. The third thing I decide is whether this point of application of elevator and the path of withdrawal is having any interferences or any hindrances from anything surrounding. If there is, I will go ahead and section the tooth such that that interference does not come into my path of exit. So the moment I've removed my, I've sectioned my tooth to remove any kind of interferences in the path of exit, I've probably removed half my tooth there itself in my mind. So the moment I do that, on that basis, now I have to decide that whether to accomplish that tooth sectioning, do I really need to gutter any bone? If I need to gutter any bone, what exact bone do I need to gutter? Now, the classical trend is that, mostly oral surgeons will go ahead, take their burr and remove the entire gutter of bone from the buccal to the distal, and that's like a classical thing, you just come there, I'm doing the guttering. That doesn't really help too much. Yes, it helps in adding inflammation to the patient, it helps in adding swelling to the patient, helps in adding some bleeding to the patient, but as far as the surgical technique, it really doesn't work our way. So this removal of bone has to be very, very judicious, has to be very, very meticulous, and has to be done only if required. The tooth sectioning is a more important step. The tooth sectioning is something which is going to make all the difference in your removal of the tooth. So when you plan your tooth sectioning, and if you have, many times if you have partially erupted teeth, or the teeth which are exposed inside the oral cavity, wherein you can directly see the crown of the tooth, many a times, if you're good with your assessment, if you're good with your planning in the instruments, you can actually go ahead and perform the tooth sectioning directly without removing any kind of bone there. So we have been doing this technique of going directly and performing the odontectomy directly without any need for bone removal. Of course, it's not possible in all cases, but a lot of cases can avoid the bone guttering part. So having said that, now this bone guttering, if it's got to be very minimal, it helps you have more sound foundation for your flap resting back, because as it is in third molar surgery, the flap always rests in a way that most of your healing is going to be by secondary intention. You do not have firm, sound bone to rest your flap, which is one of the basic principles in flap design. So when you plan your tooth sectioning and removal in this fashion, You save clinical chair time, you give your patients a lot of less inflammation than the regular technique, and of course you save a lot of unnecessary instrumentation inside the patient's mouth, which again is going to add to your clinical comfort to the patient. So just recapitulate it all. Number one, see the path of withdrawal of the tooth. Second, see where you're going to apply the elevator for this. Third, in this application of elevator and the path of exit, is there a hindrance? If that hindrance can be bypassed by sectioning, where exactly do you want to section this tooth? So sectioning has to be specific for each one. And to make your instrument reach for the sectioning, do you really need to remove bone? If you need to remove bone, where exactly do you need to remove bone? Just cutter that part so that your instrument is able to section the tooth comfortably. And after that, once you've planned this, then you go ahead with your flap design. So minimal access flap usually works. Many times we've done flapless as well. So this is the way you plan your tooth retrospective, and I hope this is going to be helpful to you in your practice. So please in the comment section just write whatever you like, and please send us your queries etc. in the comment section. We'll be glad to read and respond to all that, and I hope you have a good time doing third molars this way. So happy planning, happy execution, and all the best. Wait for our next round on coffee tutorials in oral and maxillofacial surgery with me. Bye bye.